everybody had a great lunch. Director Richards, would you go ahead and get us started? And Ms. Childress, do we have, are we online? Okay. Go ahead.
Good afternoon, members of the committee, Chairman Bear. The next agency and item on your agenda is the Department of Health. They're really here for two purposes. One, this time could be used for any callback questions the committee might have relative to their agency budget hearing in December. And then secondly, the state was awarded $205 million of federal funds under the Rural Health Transformation Program during the break since you last met in December. And they have a couple of proposals and an outline of where they think the funding could best be spent consistent with their application.
Okay. Director Johansson, thank you for being here. Before we get started, I just want to mention one thing. We have added something new to the schedule. Not everybody knows about this, but we are going to go into executive session at the end. I know we have a tour, so we'll just have to delay that tour a little bit. I've got our legal staff coming in to talk to us about the judiciary, some potential work by this committee on judiciary. So plan on that this evening. All right. And Director Johansson, please proceed.
Thank you, Mr. Chairman, members of the committee. Stephen Johansson, Director for the Wyoming Department of Health. Happy New Year to you all. Hope you had a good holiday. Ours was busy with interactions with the Trump administration and federal government on this program that we introduced briefly at our budget hearing in December. And since that budget hearing have received an award and an approval of our application for the Rural Health Transformation Program. Mr. Chairman, just very briefly, as a refresher kind of on the process where this all came from, that will queue up kind of the next steps where we see needs and interactions from the legislature on various components of this program, but also the next steps as it pertains to the money coming from the Trump administration, from the federal government to the department, and how we anticipate deploying it. We'll give you an overview in a few minutes. But by way of background, just as a reminder, the Rural Health Transformation Program came out of the One Big Beautiful Bill Act, or H.R. 1, that was signed by President Trump on July 4th. Part of that act created the Rural Health Transformation Program, where Congress appropriated $50 billion to go to states based on an approved application within very strict federal parameters on what the intended use of the funds was and how it could be spent. Following the passage of H.R. 1, the Trump administration, through the Centers for Medicare and Medicaid Services, or CMS, issued guidance on the program, application guidance, in mid-September, with a direction for states applying for the Rural Health Transformation Program to submit applications by November 5th. We submitted our application a couple of days in advance of November 5th, but what we did in the months that preceded that application was a big priority for this administration here in Wyoming. The Department of Health was to really engage the public and stakeholders as much as we could in the months of September and October. Accordingly, we traveled around the state to rural communities, held approximately 8 in-person town hall meetings, several virtual or online town hall meetings, and conducted a statewide survey where we received about 1,300 responses, which was, in my mind, a very good result given the timeline that we were on.
Director, could you kind of bifurcate that for us a little bit and just tell us, you had 1,300 responses. How much of that was the statewide survey and how much of that was the town halls?
Mr. Chairman, good question. So the statewide survey did generate 1,300 responses.
Okay. So
the attendance at the town hall meetings, it did vary. I think our largest attendance was in Laramie. That was our last meeting that we had. But typically our attendance at those town halls we went to Powell, Buffalo, Newcastle, Lander, Riverton, Evanston, Saratoga. That it varied, but typically it was between 20 and 50 people that showed up to those, and a mix of just members of the public, some county officials, folks that worked in the healthcare industry, et cetera. So total attendance, we had 439 people across all of those meetings.
thank you.
Thank you, Mr. Chairman. But what I really wanted to mention or reiterate that we discussed briefly in our December budget hearing was we took the feedback, the input, the exercises that we had people conduct in those town hall meetings to develop the survey questions that we ultimately asked on the statewide survey. Really kind of some forced decision-making, some economic decision-making on ranking priorities for your local community and for the state when it comes to rural health challenges, things like access to care, cost of care, certain types of services like a basic emergency department, emergency medical services or ambulances, primary care, behavioral health care, workforce. We developed those survey questions based on the input from the public in those public meetings. And the whole point of those public meetings and the survey was to really inform the development of our application so that it wasn't the Department of Health, my staff in a vacuum saying, here's what we think with our experience is what the state needs to do with a potentially very large sum of money. But what do our residents of these rural communities say they need, say their problems are? We really took that seriously. And I think we were one of the only states that did as much canvassing and public engagement in that 6 or 7 week period across the country. And I'm glad we did because I was quite surprised and also humbled. And as I mentioned to you in December, proud to be in Wyoming because what we received from the public, from your constituents, was not a wish list. It was not, hey, you might get $1 billion over 5 years. Here's 40 things, new services, new buildings, et cetera, that we want. The public's feedback was pretty resoundingly clear in we need the basics. And you can see that in our ranked, it's in our application, our ranked priorities that came from the survey and came from the public meetings. It was really, we want our local small critical access hospital to be financially viable, meaning there's an emergency department. There's somewhere we can go in an emergency for that basic care. We want our EMS or ambulance system to be financially sustainable so that when you call 911 in an emergency, someone shows up relatively quickly. We want reasonable access to primary care, whether that's somewhere nearby or through telehealth. We need workforce. So in these healthcare services, our communities struggle with nurses, CNAs, the same things that you've heard from me with our 5 facilities where we really struggle to recruit and retain basic professionals.
Director Johansson, could you tell me, you used the word reasonable access. Have you really honed that down to a mileage or a time frame as far as that access?
Mr. Chairman, it's a great question. We really don't have that quantified in terms of, what the public's preference was in terms of geography or drive time. The reason I say reasonable is that, again, it really wasn't, we need a primary care office, for every 10 people in this community or in this city. But, typically once or twice a year, folks engaging with their primary care provider and nurse practitioner seem to be the general consensus there. So anyways, Mr. Chairman, members of the committee, with those priorities, again, I'll just reiterate, it wasn't this wish list of all these new things that our community said they needed in rural health. Some new things through technology that we'll get to here in a minute. But the priority list was very conservative. And so again, we designed our application along those lines to really try to solve for some of these seemingly intractable service delivery and economic problems that you all know we face in Wyoming. With some of those things are very high fixed cost, emergency departments, ambulances, OB care for labor and delivery. Those are high fixed costs that rely on a pretty low volume of population to support those fixed costs. A lot of our application is designed around trying to solve for some of those problems. And you'll see that reflected in our application. A few of the principles before we developed those initiatives based on the public feedback, we wanted to go into it with some principles, and you'll see that on page 26 of the application that the federal government approved. And that was to have needs before wants. Again, in that spirit of the feedback we got, it was not a wish list. It was really the basic needs that we quantified from the public to develop these priorities. Secondly, we wanted our initiatives and the transformations and changes that we hope these initiatives produce to be voluntary. Nothing compulsory, nothing compelling that you either do it this way or it's the highway, but to have the right kinds of incentives for our healthcare providers, for our hospitals, for our EMS providers, to try to make positive change, but also make it voluntary and get the incentives right so that there's voluntary participation in these initiatives. Third, we wanted our initiatives to be easily manageable at the state level, and most importantly, to have the lowest administrative costs possible. And if you look also on page 26 of our application, we have a budget breakdown of the initiatives that we selected and proposed to the Trump administration. And we budgeted less than 1% for state administration, things like contract management, those types of staffing that needs to go to this relatively large program. We wanted to keep that as low as possible to make sure the benefits that we're trying to accrue from this program is really about access to care, funding for the residents of these small communities and for the providers that serve them. We wanted this to be low admin and easily manageable, where everything is not centralized and micromanaged out of Cheyenne. And the fourth principle, maybe the most important, was sustainability. And I know this committee will be very interested and also sensitive to that priority, because we've had, over the years that I've been here and long prior, it's very easy to receive and get federal funds that seem to fall out of the sky in these different programs, invest in infrastructure, programming, services, et cetera, and then after the federal funding period, being left in a situation where the state, the executive branch, and the legislative branch say, now what? Is it a legislative appropriation that has to keep these things going? Is it something else? And we really wanted to do our best to avoid that. And as we get into the presentation today, I hope you'll see that reflected in how we've designed it. But sustainability was a huge component, because the Trump administration provided this opportunity to us for a relatively large amount of funding. Our first year award is $205 million. And if you take that out in years 2, 3, 4, and 5, and assume that the award would be the same in those years, the state stands to receive over $1 billion through this program. That's a lot of money. That's a lot of money for the Department of Health, and that's something we take seriously. And so what we hope you see designed into our application is a priority around how to sustain that. And the bulk of our proposal to the federal government, which we're really excited that we believe we have approval to move forward on, is to take the bulk of that award, invest smaller amounts of that in these programs than folks might expect, but use a perpetuity vehicle that we'll talk about with you all and need your help with later in this presentation to stretch these benefits and these programs over a longer period of time. So instead of thinking in a 5-year timeline, really thinking in a 20, 30, 40, 50-year timeline, so that we're spending less of this award in each year and letting those deposits into a perpetuity account accrue over time to really continue forever, essentially, to address these hospital sustainability issues, EMS sustainability issues, and workforce problems. Please.
First question I have is, what kind of split are you looking at in this first year, as far as how much to put into a perpetuity account and how much to go ahead and award out in this first tranche? And secondly, how do you anticipate the perpetual fund being distributed? Is it going to be this for the same purposes? Is it going to be some other purpose?
Mr. Chairman, I'll answer both of those questions very briefly, and it's in our presentation that we'll get into more detail on. In rough numbers, we proposed to the feds, which they approved, to take approximately 70% of that first year award to be deposited into the perpetuity vehicle. The other 30% or so, which we'll get to, are on sort of time-limited one-time initiatives that we'll describe in further detail here in a few minutes. And in terms of the mechanics of depositing and spending out of that, it's what we'll talk about with the bill draft. Just some suggested language that we sent you, but something that we really need the legislature's help on. We've had good discussions with the Treasurer's Office very recently with your LSO staff on helping us health policy nerds understand the best way to set some of these things up. But the basic idea is to set up that perpetuity vehicle to where each year over time, we're targeting approximately a 4% return that would then be the investments in each year in these 4 or 5 categories for hospital incentives, EMS incentives, and workforce that would, again, on a smaller scale in a year-by-year basis, fund these initiatives that we think can be, and I know I sound like a used car salesman here, I think this could be truly transformative to some of the problems we have in our rural communities with healthcare. But the idea is that we invest a smaller amount each year so that over time, instead of 5 years of benefits, we're going to accrue decades of benefits. But Mr. Chairman, we'll get to some of that detail here in a minute.
Thank you, Mr. Chairman. And I may be jumping the gun just a little bit, but because we're talking about this perpetual fund, in your slide presentation, slide 3, it says subsequent year awards may be less if the state does not fully expend funding each year. So how do you square that with squirreling money away in an account?
Mr. Chairman, thank you. Representative Pendergraft, a very astute question and one that warrants explanation. What we have proposed to the federal government, to the Trump administration, and believe we are approved for, again, devil's always in the details, as over the next 30 to 60 days, we work with our federal project officers on these allowable costs. The idea, Representative Pendergraft, is that deposit into the perpetuity, which you'll see in the statutory language that we suggested, locks us into these specific parameters that the federal government has approved in these programs. It's not, the Department of Health executive branch is not able to spend wildly out of that account. It's for these specific legally defined purposes. The federal government would then consider those funds expended because it's going into that vehicle that supports over time these rural health transformation programs.
So what I'm hearing is, I believe. So there must be a follow-up time. Do we have an idea of when we'll have a definitive answer on that?
Mr. Chairman and members of the committee, Representative Pendergraft, just diving into the slide deck presentation that we sent you, starting on slide 2 is just the agenda, but we'll go ahead and go to slide number 3, which you referenced, just to give you the mechanics.
For the public on the screen. Ms. Childress,
Yes, I'll work on that now.
okay.
Mhm.
Let's just give just a minute so the public can keep up with us. Go ahead, Vice Chairman.
Thank you, Mr. Chairman. While she's doing that, I just had a couple of questions about timeline. I think I know the answers, but I'm sure a lot of folks listening don't. We're talking about a first-year award, second-year award. What's the timeline on that? When would we expect those funds to arrive?
Mr. Chairman, Representative Pendergraft, another good question. So you will hear me say, I believe, a little bit throughout this because this has been a very rapid cycle. And so things could change as we continue to engage more with the Trump administration on the management of this program. But from what we understand now, the award decision was made on December 29th. That's when we received the notification that we had been approved and received our notice of award. Some technical details for you, and I apologize in advance for boring folks with the health bureaucracy. We've been asked to modify a few things with the application materials, mostly technical items in the federal grant system, different boxes that need to be ticked, et cetera. Adjust some contact information for the staff that are listed on the application, et cetera. And we also have to revise our proposed budget. As you might recall, the federal government instructed every state to hypothetically consider a $200 million per year award in their application to develop their budget. Now, obviously, states received varying amounts in late December when awards came out. So we received $205 million, which was over that amount. So we've been instructed this month to revise our proposed budget, which would then give CMS, the federal government, 30 days to approve that revised budget. To answer your question directly on timing, the simple answer is I don't know exactly the timing of when the funding would be actually distributed to states, but we assume conservatively within the next 30 to 60 days, assuming these subsequent approvals go the way we believe they will.
Well,
Okay, so we get the first payment in 30 to 60 days. When does the next one arrive? And then is it an annual after that?
Director?
Mr. Chairman, Representative Pendergraft, so in this 5-year federal award period, the first federal award year is essentially December 25th of last year, so a couple of weeks ago, through the end of the federal fiscal year, which is September 30th of 26. The timeline in order to spend those funds, every federal award year allows obligation and expenditure of those funds one federal year subsequent to that award period. So to give you a crude example, with our first year award, which is December 25th of 2025 through September 30th of 2026, $205 million, we essentially have until September 30th of 2027 to obligate and spend those funds. And for the subsequent award years, year 2, year 3, year 4, and year 5, the same kind of logic applies. So essentially, through the end of federal year of of calendar year 2032 would be the federal award period. However, Wyoming's unique in our application and what we proposed. We kind of stand alone as a state that proposed something I think very creative in this perpetuity account, where while the federal expenditures will absolutely happen in that window that I just mentioned, we propose with our hospital incentives, our EMS incentives, our workforce programs that we'll get to carry those in perpetuity every year, essentially until the perpetuity corpus runs out, if it does. That's the idea. And again, we're excited that we believe we have some buy-in, that the Trump administration and federal officials, I hope, are as excited as we are. And really, it comes from the feedback that we got from the public. I think I mentioned this in our December budget hearing, but it's worth reiterating. We asked a specific question on that statewide survey to try to gauge the public on, would you prefer us to spend in a 5-year period on short-term temporary needs one time right now, or spend on fewer priorities on basics over a longer period of time? And the results were pretty unequivocal that the public favored the latter. And we have that quantified in the survey data that I believe we sent you. If not, we're happy to send that to you. And again, seeing some nod of approval and some agreement from the federal government was an exciting development last week on Monday, that we believe we have a potential path to a green light to be able to do that.
Go ahead.
Last question. I'm jumping to the memorandum dated December 25th. Thank you for that. It was very helpful. Amendment A was very helpful. It says the primary vehicle that we intended to use to avoid this is the Rural Health Transformation Perpetuity. This will follow the federal funds. This will allow the federal funds to serve as the corpus, and a fixed 3 to 5% return on the corpus be used every year. And then it says, while the corpus is not inviolate per se, those words scare me. So I would like a little elaboration on that. It says, this return represents, quote, a safe withdrawal rate that can be sustained for a long period of time. When I was 4 years old, 3 months was a long period of time. So they seem, could you add a little bit more to that paragraph, please?
Director Johansson.
Mr. Chairman, thank you. Representative Pendergraft. I'm going to defer to our deputy, Mr. Franz Fuchs, to talk about the perpetuity, where we are with it, and answer some of those questions, if you'll allow me, Mr. Chairman.
Before you do, I just want clarification. The 4% is not 4% of earnings. It's actually 4% of the total corpus.
Right.
Correct. So theoretically, 25 years or so it would last.
Mr. Chairman, I think depending on
Yeah.
the returns that were accrued.
Right. Could be longer.
Could be longer, absolutely. We, to that point, Mr. Chairman, and forgive me for jumping in again here, we kind of crudely modeled this out as a 30-year,
Sure.
30 to 40-year period, but
probably
it could
still-
certainly be longer.
That's probably still conservative. This, and when you modeled that out, what were the earnings or well, what were the payouts across the 30-year period?
Mr. Chairman, I'll defer to our deputy here. Some of this is not absolutely written in stone
Sure.
and pretty
I
dependent
understand
on.
that. And we're depending on the stock market too. Understood.
Mr. Chairman, my name is Franz Fuchs, Deputy Director, Department of Health. Thanks for having us again this afternoon. Mr. Chairman, Representative Pendergraft, to your question on the perpetuity itself. Sorry, refresh me on your initial question. I apologize. I blanked on your
Yeah, I was looking at the memorandum which you sent to the Joint Appropriations Committee on the 25th of December, and it was answering a number of questions that we had brought up. This particular one says, while the corpus is not inviolate per se, so I guess that was partly answered in the 4%, the spending policy. Are there any other terms in there? In other words, what I'm curious is who could decide, okay, we've had enough of this, we're just going to spend it because that was the initial idea. Who makes that decision? Can the Department of Health do that alone, or do they need spending authority from us? So a little clarity on that. And then I think we've answered the question about how long that we're looking at 30 to 40. So I guess that's what I'm looking at. How do we define inviolate?
I think you've answered your own question there, Representative. It's you and the rest of us that'll make that decision. And we often do deal with these inviolate, statutorily inviolate accounts, which we cannot hold future legislators to a particular standard. So they can certainly undo our work at any time. And that's why this is a per se, because we will try to guide our fellow legislators in the future to not rob this fund. But the only way you can make it a permanent inviolate account is to put it before the people and put it in the Constitution. So I hope that answers the question. And if you have any other details you want to add, please do.
Mr. Chairman, if I may, first of all, well said. If I may, there's kind of a natural check and balance here too, because we're talking about two different dynamics. There's the legislative establishment of this perpetuity. And to the chairman's point, guiding that for future legislators is I think the goal. However, with the federal government being involved in the approval and our use of their funds, there's also restriction on that to where if a future legislator said, let's say 2-3 years from now, a legislature said, we're going to take money from that corpus and invest it elsewhere. Let's say it's even in a health related, area, but it's not within the approved federal parameters of this program, then that money would essentially be in violation of federal law and could be clawed back by the federal government. So there's kind of two checks here where legislative establishment of the account, I think, is necessary. But also, in order to get approval from the federal government on this, one thing we answered them on in December when they reached out about this particular proposal was that it would be structured in law to be, restricted to these approved purposes. So I think even in out years, the federal government would be monitoring that for compliance. And if the legislature or the executive branch drifted outside of those purposes, you'd put that funding at risk for clawback.
So you believe that would be the case, clear out to the 30-year limit that you kind of see on this account?
Mr. Chairman, it's a very good question. I can't predict the future there, but yes, I think even if you have carryover or spending that's happening that was generated from federal funds, I think they have authority to go look at the appropriate use of those funds through their audit parameters.
Director Hibbard, I think this is something that I'd like to have you weigh in on, because we have tobacco funds and we have Volkswagen funds that kind of fall into the same line, although it's from the judiciary rather than the federal government. Is that how those operate as well, where the expenditures have to be within those guidelines?
Mr. Chairman, yes, you have specified in legislation that the tobacco funds will be used in the fashion that they are for the 4 agencies that we deliver upon. We had that conversation. We also had a conversation about the opioid settlement fund being in the consumer fund now, that there's an opportunity to delineate that as well as an interbearing account. So this would be subscribed in that fashion as well. And your point about taking it to people for a constitutional fund, like the permanent trust fund or common school permanent land fund, that would be something that would lock that in further.
We don't typically do that for these smaller accounts like this would be. I think at the max, 70% of $1 billion, 700 million is,
Yeah, absolutely. Another
biggest
example
this
would
would ever
be the
be.
correction funds that we have, the $10 million takedown on the SIPA, that kind of thing.
Mhm.
School finance reserve account is another example. It's got $88 million in it. I mean, so there's several of those.
So just for the edification of the committee and the public, did I hear you say that the tobacco funds are statutorily required to be spent the way they are, not necessarily from the settlement of that
Mr.
case?
Chairman, yes, and there's expectations from the federal government on tobacco settlements as well. That's a different control, would be similar to something like this. You know, I'd expect some level of expectations to be established and agreed to with the federal government on this, as well as the opioid settlement fund.
Thank you. Please proceed. Well,
Mr.
let me just see if there's any other questions right now. Okay, please proceed.
Mr. Chairman, members of the committee, we'll move to slide number 4 on your presentation. So just a few summary bullet points here. As we've already talked about, we need your help on a few items. One is the spending authority for this program. As you remember, we had a draft budget request in front of you for our December budget hearing. I believe that total was about $344 million that we had estimated based on what we thought we might receive over the initial period that really took about 3 fiscal years into consideration. Timing's always interesting with these grant programs because they're running on a federal year. We're budgeting on a state fiscal year. So we are recommending that exception request that you saw in December to be adjusted. To be very clean, we just looked at our award that the federal government just announced last week, and we kind of scaled that out to 3 state fiscal years, which takes us to approximately $512 million in that new unit, as you recall, that we proposed creating. The reason for the new unit 0491, was to make sure all of this is as clean as possible, as transparent as possible, that since it's a relatively large amount of money, that the department isn't, putting that into multiple units depending on the program or the service. And it's very hard to track when we come back to you during the interim, during supplemental sessions. So in 491, we are recommending to adjust that exception request based on the award that we received from the Trump administration. The second thing, as we've already been talking about, is the perpetuity statute, and we'll get to that specific language here in a few minutes. But it really allows these funds to be invested in order to maximize the funding for the initiatives, and we've designed it to be consistent with that 4% return that we talked about. That statute language that we'll talk about here shortly also defines the allowable purposes. So both in state law, but mirroring what the Trump administration has approved to try to keep those restrictions in play. You'll see that in the language as well.
Director, just one moment, please.
Please.
Vice Chairman Pendergraft.
Thank you, Mr. Chairman. That 344, you had requested effective immediately 200 million. Does this change that number?
Mr. Chairman, I think if there was a carve out between effective immediate or effective on July 1st of this year, I think it would be prudent to at least have that 205 million effective immediate. I say that with a little caveat because given the timeline of this, how this is going to be structured with RFPs, requests for applications on the various programs, there's likely some time between now and July before we'd be drawing down all of those funds. But I do think some effective immediate, if not the whole thing, would be necessary just so we don't get into a pickle with not having the state spending authority on something the federal government has approved and we'd be looking to allocate, let's say in June. So that not the greatest answer to your question. If you were asking a card-carrying bureaucrat in the executive branch here, I would say it's just as clean to appropriate that spending authority, make it all effective immediately, but it won't be used immediately given the scale of this award.
Yeah, well, would the treasurer have access to begin investing those funds in a long-term investment? I guess that would be my question.
Mr. Chairman, that's a good question. I think that would be a need to generate those returns in the first year. That with the spending authority for the budget request, combined with if the perpetuity statute were authorized by the legislature, that essentially allows those appropriated funds to be deposited into that account and then to be used by the treasurer's office for the investments. I'm not an expert in that field. I think some feedback from either LSO or the treasurer's office would be warranted. As I've said, we've met with them a couple of times and gotten some feedback. But I believe that effective immediate would be necessary in order to generate the returns on the account.
Director Richards?
Mr. Chairman, my suggestion would also be to make the full $205 million effective immediate. That allows 70% of that to be invested as soon as possible rather than waiting 3 months. I'm given the opportunity to comment,
Please.
if it pleases the committee on this. Their recommendation, you're really 3.5 years. You could make that same argument for year 3 as well. Best to just authorize the full 615 million rather than the 512.5 million and miss out on 12 months of potential investment earnings.
And Mr. Chairman, I appreciate Mr. Richards' comments. Again, not as much of an expert in this world, but I did want to mention, because it's important, throughout each interim year that you all meet and each subsequent session, supplemental session, obviously there's opportunities to tweak the amounts based on federal decisions if our award is more or less, depending on how the first year goes. You'll certainly have that opportunity. So it's not that there's inability to change on some of those numbers in future months, but certainly agree with Mr. Richards on the ability for the treasurer to have access to those funds for the investments.
I don't want to necessarily take you off of your presentation while the public's looking at your presentation, but I'm getting a lot of feedback, with the continuing resolution not changing the supplements to healthcare, where some of my constituents, their premiums right now are tripling, quadrupling. And I don't think the people, when you had your town halls, really were aware that that was going to happen. So from your perspective, is this investment going to address any portion of that? And if we have a mass exodus of Wyomingites from insurance, what does that do to our ambulatory hospitals and everything across the state, in your opinion?
Mr. Chairman, first of all, I think you're right. It's difficult for folks to know the ramifications of expiring subsidies until they happen. And I think we've seen that as of last week. With, again, a congressional modification could still happen on those subsidies. We're monitoring that. But absolutely, I think with the premium increases for certain populations on the marketplace, those increases have essentially been felt starting this month. And some of them are pretty significant in terms of the cost of that insurance without those subsidies. To answer your question directly on what portion of this rural health transformation proposal could address some of that, it's a much smaller component of this proposal of our application, which was the catastrophic public health benefit that we termed Bear Care, which was to essentially cover the bare necessities. If you were going to choose to go without insurance because of the cost, could you have access to a product that prevented financial ruin should you have an accident, get into an emergency situation, a cancer diagnosis, what have you? If you'll look on the last slide of this presentation, which is slide number 8, you'll see that major medical plan, the Bear Care Major Medical Plan, is a very small component of the proposed budget for this program. And that's essentially because if you all were to authorize us standing that up, it would self-fund over the long term through premiums from individuals and small businesses. So you'll see there, it's about 1.4% of our overall allocation, and that's really for startup costs. Interestingly, the perpetuity itself for catastrophic claims, larger claims that might come in, the perpetuity reserves would essentially protect the state against some of those claims so that we'd be able to pay them. But Mr. Chairman, that's the one area on the health insurance issue that's transpiring in the Obamacare marketplace, again, outside of all of our control, that could help address that. It's not a replacement or a complete solution to that problem because we're not offering an alternative health insurance product that covers the same thing. But it's an alternative in a way that is a very different type of product that says if you are choosing to go uninsured as an individual, here is something at a lower cost that would protect you against those larger financial issues should you need that level of care. And secondly, as we talked about in December, for small businesses outside of the individual marketplace who have, a small number of employees and are not required to provide health insurance to their employees, it could be a product the state could offer, supported by these funds, to give those businesses an option instead of a fully insured product, which can be very expensive for small businesses, or offering nothing and struggling to recruit and retain staff, something kind of in the middle of that continuum to offer some catastrophic coverage for their employees. Mr. Chairman, you'll notice in the bill draft language that we provided to the committee, we did not include Bear Care authorization in that. However, I'll state unequivocally, we will not stand up that program without legislative authorization. The reason it's not included in that bill draft is because we really wanted to keep that isolated to the perpetuity account to keep it clean, but also to give some discretion to the legislature on what's the best way to stand up that catastrophic benefit should that be the preference. Now, the Trump administration has approved the concept. We can move forward doing that, but I think there's some time that we could take either through the interim with this committee, others, to get that right in statute and potentially set that up for either a January 1st, 2027 or a July 1st, 2027 launch date. So that, again, it's a smaller component, very small component of this overall proposal. If you look at that table on slide number 8, the bulk of our investments are really going to our critical access hospital basic incentives, our EMS, emergency medical services incentives and regionalization, our workforce education awards. That's the bulk of what we're trying to accomplish here. But that is one potential option, Mr. Chairman, to the constituents that you all have, those that we hear from too, that are saying, wait a second, my health insurance is now completely unaffordable. It's a modest approach to try to offer something as an alternative, but certainly not a replacement.
Mr. Chairman.
You're going to have to help me. I'll be
Just
right
when
with
you get there.
I'll get right to you. Director, since I left the military, most of my life, I've had catastrophic care, and I've been able to get it whether there was an Obama exchange or not. And so I just have to ask you, this Gordon Care, how is it different than the Medishare that I've had in the past, or Aflac, or anything else that might be out there for people to purchase? And why would they want to purchase it from the state versus one of these companies?
Mr. Chairman, it's an absolutely fair question. We can call it Stephen Care. We really have no preference there.
I have a preference.
I'm sure you do. No, that's totally fair. I'm going to defer to our deputy. Again, this is a concept that we started tossing around about 3 or 4 years ago. The subsidies and the enhanced subsidies had not expired on the ACA marketplace, but we just saw some uncertainty in Obamacare and incredibly increasing prices that were mostly supported by federal subsidies. So if you look at the allocation of cost in the ACA marketplace, it looks oddly similar to Medicare in that it's basically 80% federally funded, right? So That same kind of uncertainty of what happens to premiums, congressional decision-making on subsidies, we know that's always can be variable. So about 3 or 4 years ago, we were looking at, since a lot of these catastrophic plans, to your point, through the ACA, have been really curtailed over the years in favor of these larger insurance products, 10 essential health benefits, et cetera. Can you still get them? Yes. Are they as common and affordable? No. And so we started tossing around this idea of, does the state have a role? And I think that's a fair question if it does. Does the state have a role in offering something like this? Because as a state entity, we can be exempt from some of those ACA regulations. But I'll defer to our deputy, Mr. Chairman, because I'm probably not as articulate in that
Director, I
answer.
will say that I'm pleased that you were not surprised that Obamacare is destroying healthcare in America, especially with your experience with other government-funded healthcare. So I appreciate that that's your point of view. Mr. Fuchs, please.
Thank you, Mr. Chairman. Just a couple reasons why we thought this might be attractive. And I think it's important to note that enrollment in this plan would be completely optional, right? So we would see, the proof of the pudding would be in the eating as far as how many people would actually enroll. But one, what's out there today is a combination of health sharing ministries, maybe some farm bureau plans, those kind of short-term indemnity, type policies. They all vary, right? So an indemnity policy will pay a capped amount per incident, for example. Bear Care, or the whatever major medical plan we want to call this, the idea is we will be reliable. We will be there. We will cover all the expenses from that emergency anchor visit. So the idea is it's more comprehensive coverage. It's much more like a traditional health insurance plan where it would cover all of that, not just an indemnity cap. But it would be limited to those emergency type anchor events and the subsequent care. Second point, I think a lot of data on Medishare and health sharing ministries, it's scant. There's not a lot of standardized data out there. Colorado did an effort back a couple years ago to try to require reporting from them. But what they found was that approximately on average, 40% of what people pay in terms of premiums or membership fees gets spent on medical expenses. It was a very, very low medical loss ratio. The standard for health insurance is 80%. So it was far lower than what health insurance companies put out there. And with this particular program, we would anticipate a medical loss ratio of 95% or above. We really want to keep the administration of it as lean as possible, make sure that all the benefits that the fees that people are paying go to medical expenses and are actually, end up paying out for those medical expenses. So I think reliability is also a concern. I think reliability is something that, we could guarantee beyond what is available today.
Mr. Fuchs, you did hear your director say that depending on the Congress to make some of these decisions is what's created some of the problems with the other insurance that we're talking about. So government involvement is not necessarily a quote unquote guarantee. So caution I would recommend when presenting this as something that would be better at guaranteeing an outcome than the private sector. But also, we've talked about the sorry, I have cold brain here, so the solvency of this thing, and future legislatures can change things, and that solvency can go away. So I would just caution you on thinking that maybe this would be a better solution just because it's more sound than what can happen in the private sector. So I appreciate your answer, and Senator Grew.
Well, I want to just kind of play off this because, we heard from our insurance commissioner that there are hundreds of products available today for me as a business owner to provide this coverage. Hundreds. Now, I don't know how many in this room own private businesses and are providing coverages. I am. I'm one. And I don't know how many others there are, but I know how much it costs. I know what it covers and I know what it doesn't cover. And I know that I'm actually self-insuring for my employees to get a deductible down from catastrophic catastrophic for them is a $10,000 deductible. Well, I have to to get the premium down, I have to go with that high deductible, but I know where they're going to go if they have an accident, if they have a problem, they're coming to me. So I'm self-insuring for the 10,000 for all my employees, all 170 across the board. So I bet, that's why I don't go to Vegas, because I'm rolling dice every month that I'm not going to have more of them go to the hospital than I am of what my payment is. So when you talk about providing this coverage that's out there, you're doing it because you feel, and with all due respect, as far as, I didn't hear you say that the government destroyed healthcare. I didn't quite hear you say that, but maybe you did and I just missed it, but it's okay. I won't go there. But the point of the matter is, for a lot of us, having something to cover that catastrophic cap might make it more affordable for me to provide that maternity or the accident coverage or the things that my employees who are generally younger might be able to break into. Is that what you're trying to do?
Mr. Chairman, Senator Guru, I think that's a good example of the possibility of a program like this. It frees up a small business to either self-insure, finance, or directly purchase other things outside of an insurance vehicle. Things like direct primary care, pharmacy benefits that could be self-insured at a lower cost. So general answer is yes. Again, devil's in the details here, and we want, if this were something that our decision makers were interested in, we want to get this right through good study and legislation of what the state's role should be, how it should be covered. And to your other comment, just to clarify my statements, it would be very silly for me to say that something as massive and large as the Affordable Care Act ruined healthcare. It would also be silly for me to say that there were not absolute downsides and consequences to it. Of course, there are. And I think one of them is the relative opacity or the opaque nature of healthcare costs. You just don't see that in folks who purchase insurance on the marketplace, or really in general, to know what this is costing. Because when you have a premium that's subsidized, say you're paying $50, $100 a month, but the actual loaded cost that the federal government is paying for is thousands a month. You don't see that cost in the care that you are consuming. And so I think there's a relative amount of surprise in the population when health insurance premiums go up. And that's related to the cost of care, especially in places like Wyoming, where there's not a lot of providers. Negotiation power can be an interesting dynamic of what's the actual cost of this service versus what my insurance pays or what I'm held out of pocket for. Those are real problems in health insurance and in the ACA. And so I think this is one very small part of this program that could be a solution in the future for both individuals and small businesses who have to make a choice between comprehensive coverage and treating healthcare coverage more like how you insure your vehicle, where the insurance product most of us have doesn't pay for cosmetic procedures or oil changes, et cetera. It pays for, catastrophic things or comprehensive coverage to the body of the vehicle, or if you get in a crash.
Follow?
Go ahead.
Yeah. So let's game that out a little bit. And I understand and I don't disagree with the good chairman when he talks about some of the downsides of government healthcare. And that's why I didn't go on. It was the easy thing to do at that point, to fold up the insurance program and say, go on the exchange and I'll pay for it. But we didn't do that because I knew this day would come. And now people that are trying to go and buy insurance in the market, even though our insurance commissioner said there are hundreds and hundreds and hundreds of policies available, I have yet to find anywhere near the coverage or the affordability that we have today. So that's why we stuck with that. And that's why I think this catastrophic idea might have some applicability to folks around the state. The other question I have about all of this is, as far as us writing legislation, we write legislation that gets you a perpetuity fund, but do we need a separate bill then to talk about where we want these funds to go, or more importantly, where we don't want these funds to go in the short term, medium term? Because I think one of the things the committee's talked about, no matter what form it takes, I think all of us have an interest in fulfilling our legislative responsibilities as far as how these dollars get doled out and not necessarily just leaving it open. And that does not saying nothing about anyone who's currently in office or who may be in office a year or 2 or 3 down the road. But that's something I think everyone in this group was seemingly that I've talked to has a keen interest in.
Mr. Chairman, Senator Guru, and for the benefit of the committee, jumping to the proposed bill draft that we sent you. It's your second document that we sent you yesterday. We tried to outline those parameters of everything that's specific to what the Trump administration has approved in our application. Ultimately, that's the sideboard that needs to be first established because we can't violate that, the state can't violate that, lest we want to risk the overall award that we've received. So in the perpetuity statute, Senator Guru, you'll see those parameters included in there. And I think that that essentially answers the bell on what the perpetuity itself would finance. To your broader point on, guardrails, et cetera, from the legislature, I would just urge some caution, not because we don't want involvement or guardrails. Obviously, this has been a rapidly developing program, but the Trump administration has been very clear with us that anything outside of these approved purposes that are within our application risks clawback from the federal government, and we are not authorized to spend any of this award on those areas. So we're already checked on that. And, any modification to where this money gets spent, if the legislature said, hey, we really want to invest in this particular service over here that was not in the department's application, that would risk a clawback on our entire award.
Mr. Chairman, and that was, if I can, if I can.
Yes.
No, that was why I specifically put emphasis on the not part of that question, because I do realize and heard what you said about staying within those federal guidelines. That everyone wants to stay within those federal guidelines, but inside that sideboard, having the ability to say, hey, not so much on this, or hey, more on that, inside that box, I think is what we were looking for. So thank you.
Director, I'd like to just take a brief moment and acknowledge the Secretary of State has come in here and per our request, but the request has changed. But I want to make a note that the Secretary's office has shown up and answered our request. We apologize that the cancellation of that didn't occur quickly enough to not interrupt your day.
Okay.
Thank you, Mr. Secretary.
Thanks.
Thank you.
Sorry, Mr. Secretary.
Yes, sir.
Thank you.
We're gonna talk. No problem.
Mr. Chairman, wrapping up our presentation.
Please proceed.
We're happy to walk through the proposed.
Director, one moment,
Please.
please. Vice Chairman Pendergraft has another question.
Thank you, Mr. Chairman. I did want to weigh in on that subject. Senator Giroux appropriately pointed out that we were told in testimony yesterday that there are literally hundreds of companies out there offering catastrophic insurance, a product like that. I believe that I heard you in your testimony say that a government program, a state program, would have certain advantages because it didn't necessarily have to follow all of the regulatory burden that the others do. And so that to me puts up a red flag. We have the state stepping in and competing with private business on an unfair level. And I've always been of the impression that it was the responsibility of the state to provide a level playing field so that anybody who wanted to build a business could build a business. So philosophically, I have a real problem right there. But if you have one particular option that doesn't have to play by all the rules, and this particular product we also heard was more profitable than many of the others. So you're taking away one of the more profitable products from private insurance. You're playing on an unfair playing field. Doesn't that lead you to believe that of those hundreds that might drop to 30s or 40s, does that not lead us closer to a one-payer health system? And can you say anything to assuage my fears?
Mr. Chairman, Representative Pendergraft, I'm not sure I can. I'll make a few comments on, one thing the Affordable Care Act did was really curtail legally the ability for those types of policies to even be sold. You'll hear people in the insurance industry say essentially they've been on a direction to illegalize them. And I think there's truth to that. So I think the ability to even offer those products has changed in the last 10 years, to be sure. But as Mr. Fuchs also mentioned, I just think there's, while there might be products out there, the take-up rate doesn't suggest their popularity. With potentially 10,000, 15,000, 20,000 people looking for alternatives because of this federal change in subsidies, I would just offer that I think it's worth consideration at the very least on if the state has a role in offering a product in that sort of landscape. And again, I'll be humble and say I'm not entirely sure that it does, but I think this creative approach does, in my mind, lend itself to at least fair discussion on. You have one side of the coin, which is profitability and private business that may offer those types of plans and potentially pay a medical loss ratio of 40%. The rest goes to profit and admin, versus what your constituents and the people might be seeing in those products when the accident does happen, and sometimes those products are not there to pay. That's just the harsh reality of certain types of catastrophic plans. You've probably heard the same in the long-term care insurance market, where for the last 20, 30 years, it's really been spiraling down. And folks who do the right thing, save money, buy long-term care insurance, they hit 75, 80 years old, need to stay in a nursing home, for example, and the policy's not there. There's some rider, there's some clause that eliminates their willingness or ability to pay. I'm not making an ideological comment one way or the other, just what we see in the types of coverage that people have. So to conclude, Mr. Chairman and Representative Pendergraft, I think it's worthy of a consideration and debate on whether this is a good direction to go in. Again, the concept, I think, was intriguing enough to the federal government, to the Trump administration, to say, hey, while all of this is going on with these expiring ACA subsidies and these questions about what does that cost truly mean, here's one state that's at least considering an alternative to cover this. Please.
I'm certain we will debate that. Whether it's Gordon Care or Bear Care. Mr. Fuchs.
Mr. Chairman, Representative Pendergraft, I just to add one note. I think there's an issue, subsidies aside, federal spending aside, there's an issue with insurance generally, is that insurance tends to reduce people's exposure to the cost of care, right? And so if you're looking at healthcare costs, what's the best way to really try to reduce healthcare costs broadly? It's trying to get as much free market activity in the healthcare market as possible. However, with healthcare, it's weird because you have services that you really could shop for and services that you really can't. And so the idea with this is really try to limit the insurance coverage to just the stuff that's not shoppable and say, this is stuff that you get in a car accident, you're unconscious. You don't get to choose what ambulance takes you to the hospital. You don't get to choose any of that. You're on the hook for it. And that's the idea of covering those non-shoppable services. But we're reducing the footprint of insurance to expose all those shoppable stuff to people's own market-based preferences. And so it's kind of reimagining what health insurance could be in a way. Whether it's the role of the state or not, I think that's a question for you all as electeds. It's certainly not our role. We are just presenting the idea.
Senator Larson, sorry I passed you up there.
Oh, we're good. Thank you, Mr. Chairman. Thank you for being here again. I guess my question is when are we going to get in the weeds a tad bit? I mean, we're talking about perpetuity revenue being put in certain spots, but will we go through some of these items? Like what's EMS regionalization mean? We're going to have a EMS in Park County and it'll be between Powell and Cody, or what does some of this mean?
Director Johansson.
Mr. Chairman, Senator Larson, happy to walk through these initiatives that were approved by the Trump administration. Give a few bullet points if that would be helpful.
It would. Are you ready to go to that? Have you finished your
Mr.
presentation?
Chairman, happy to do that.
Let's finish up his presentation because I don't think that's only a minute away. And I also have detailed questions I have about that as well. So go ahead and wrap up the presentation, then we'll get into that.
Absolutely, Mr. Chairman. So this last slide that's been on the screen for a little while, it outlines the 11 initiatives that were in our application and approved by the federal government. The first one, which you see represents about 28.3 of the award that we've budgeted, 28.3%, is what we're calling the Critical Access Hospital Basic Incentive Program. This is, again, stemming from the public feedback that we got during the application development. Your constituents, the public in Wyoming, wanted to ensure that their small frontier critical access hospital was financially sustainable. And we know that's a mixed bag of financial sustainability around the state, some doing better than others, some on tighter margin than others. What this does is provide an incentive program that would provide in perpetuity, funded by the Rural Health Transformation Perpetuity, a $1 million per year incentive program for hospitals that focus on the basics, an emergency department, OB or labor and delivery care, potential partnership or ownership of the local EMS agency, because as a critical access hospital, if the EMS ambulance service is provided out of that hospital, the federal government already gives you a cost plus reimbursement. So it's a more sustainable path. But those incentives, they're outlined in our application on a tiered basis. If Hospital X said, we would like to participate, we'll guarantee that we offer these basic services, we would provide a certain amount of annual incentive in perpetuity forever. If they went a step further, in certain cases, doesn't work for all, and curtailed some services that might be redundant regionally, things like elective procedures, elective surgeries, et cetera, that are often used to cross-subsidize lower reimbursement rates from some payers, then we would offer an additional perpetual incentive to that hospital. With the idea being in your smallest critical access hospitals, we have an effort in conjunction with the federal government, who really prioritized this right-sizing issue, to focus on the basics and say, if we can sustain those indefinitely, we should offer some reward or incentive to do that. The EMS, the second one, the EMS regionalization, very similar concept, but we've studied this issue, as I know you all have in the legislature, ad nauseum for 10 years. And we know that we have a financial problem with EMS service delivery throughout Wyoming. Again, the basic economics is it's very high fixed cost. One ambulance costs about $500,000 a year. Very few EMS agencies could ever bill enough, even if they billed perfectly to Medicare, private insurance, Medicaid, could ever collect enough revenue to break even on that $500,000. So there's a cost problem. How does that get subsidized today? It gets subsidized through volunteer labor, through fundraisers, bake sales, all those types of things. And you hear, I know you hear constantly, our EMS service is struggling. We don't know if we can make it. And there's been questions and bills in front of you for years of, should the state just appropriate tens of millions of dollars to pay the cost of EMS? That hasn't happened legislatively. And what we propose here is to offer a similar incentive that if you move in these directions that we believe make you more sustainable, consolidated administration regionally, we think that's and some EMS agencies have already done that, is a successful way to go. Participating with us, some participating with us in a consolidated billing contract that we could help with our purchasing power, get them centralized billing to generate more revenue. Again, a few strings attached, but if the EMS agency participated in those things, again, an annual perpetual incentive payment to essentially cover some of those high fixed costs and allow that EMS ambulance company to not only survive, but thrive into those out years. The third one, and Mr. Chairman, I won't go through all of these.
Before you go on,
the
I
top
just want to
ones.
make sure, Senator Larson, do you have any follow-up on that particular one? Okay, please proceed.
Mr. Chairman, the third priority that you see in the table is on workforce education, and I would lump in the next category of physician graduate medical education. This is all in the workforce bucket, and this was a relatively large part of our budget allocation in the application, which is to bolster and develop our healthcare workforce in Wyoming. Our university, our community colleges, our local communities have done a good job over the years trying to increase the pipeline, programs for CNAs and nurses at community colleges. Again, a lot of successful work going on. What we struggle with is the out-migration of that labor to larger markets in Colorado down south, Montana up north, out west in Utah. Very difficult to keep people here. These funds are dedicated to that purpose, to essentially offer a career pathway to some of these folks, especially our young kids that might be interested in this line of work, and say, we will pay for your education, CNA, nursing, nurse practitioner, even physician, in exchange for service award guarantees on, length of service guarantees on the back end. We pay for some of this education. You live and work in Wyoming for a minimum of 5 years, and we try to bolster the workforce in our rural and frontier communities that way. Some of our programs over the years that we've had in the department with similar missions, loan repayment, et cetera, there's success there, but they're extremely costly. So with the advent of these federal funds, we think there's an opportunity to really scale that up over 5 years and try to develop a larger amount of nurses, CNAs, emergency medical technicians, and EMTs and behavioral health workforce. And that kind of rounds out, Mr. Chairman, the perpetuity funded initiatives. Below that line, when you get into integrated primary care, technology adoption, exercise and diet promotion, these are time limited, one-time grant programs that are more fully described in our full application to the federal government. We're happy to answer any questions you have about those today, but focusing on the perpetuity
Mr. Chairman, Director, since you're on that
up without legislative authorization. We don't have the legal authority to operate a program like that, even if we wanted to with these federal funds without your authorization. If that were not authorized, if that were not stood up, then essentially we would do our best to reallocate that small amount of money that's budgeted for it into another initiative if the federal government would allow us. That would essentially be our approach.
Other questions? Okay, so a couple of things. I'm sure you're probably aware of the Kemmerer Long-Term Care Facility and their requests of the SLIB board. And they're seemingly in a bind. I don't even understand the entire situation not being on the SLIB board, but do you see that project fitting into this infrastructure and pilot projects portion of this funding?
Mr. Chairman, yes, but let me caveat that. We have a portion of this proposal that's been approved that provides grants to hospitals for what we call swing bed conversion. Those are hospital beds that are converted essentially to be able to swing between hospital inpatient and long-term care beds. A lot of hospitals around the country use that. There's a more advantageous federal reimbursement rate for swing beds. And so you see a lot of that conversion happening. We do believe it's a financially sustainable path for certain facilities to go down to convert to swing beds and thus be more operationally and financially sound. The timing of this is what I'm not sure would help the Kemmerer facility because we're talking, probably several months in development with our hospitals, with feedback from them on what this application would look like, what the agreement would look like to be part of this program and essentially receive those swing bed grant dollars. So in theory, it could absolutely be a help to that facility. I'm just not sure operationally if it's in enough time for them to not have to make other decisions. I wish I had a better answer for you. I just can't guarantee that this program will be up and running, next month, given that the federal government has kind of decision-making authority on when we can get started.
What is the timeline for the Kimmerer long-term care facility?
Mr. Chairman, forgive me for not having all the details here. My understanding is that that issue will be on the agenda at the February SLIB meeting. I would have to consult with the hospital so I don't misquote or misspeak on what their timeline is for any sort of serious decision-making they would have to have. We're just aware of it on the compliance and licensing side of what the facility is considering. We generally don't get involved in the financial decisions.
So you all have done an excellent job of, I'm going to call it twisting the arm of the federal government to get this thing through, stuff that I think our staff and us were kind of surprised that you were able to get accomplished. So well done in that regard, but I guess I got to ask you, any chance you can get them to allow us to purchase across state lines on these insurance policies? Because that would definitely solve a lot of this insurance trouble. We might send you back to do just that.
Mr. Chairman, feel free to send me on a fact-finding mission. That's an interesting issue. A lot of that does happen in this area across state lines. But it's certain, I'll answer this way. It's not part of our application to focus on that.
Thank you. All right. I think we've exhausted all the questions we had for you. We certainly are taking this up as a matter of legislative action. So we'll be working on this and we'll keep in touch with you to make sure we get it right. Oh, Senator Larson.
Mr. Chairman, are we going to go through the proposed bill somewhat?
I think we will do that.
No.
Mr. Richards, do we want to do that now or after you've had a chance to draft something up?
Mr. Chairman, actually working the bill is scheduled for next Thursday. However, we would, Tamara in particular, would be open to additional direction from the committee on any of the points discussed. For example, the amounts to be made effective immediate, who makes the appropriation, if this is a standalone bill or in the budget bill, or those types of any additional direction we can get earlier, whether it's not, even if it's not today, if members want to visit about it and get back to staff, that's fine too. But those details would improve the discussion next Thursday.
Yeah, I think what would be helpful is if we did this discussion tomorrow with the list brought to us with those questions, and we will discuss it and provide direction for the staff at that point. Okay. Vice Chairman Pendergraft.
I did have some callback questions. You still want to do those?
Yes, let's get it done quickly, please. As quickly as you can.
I do have a number of questions. We had discussed possibly having another subcommittee meeting, and it was decided that we would just fire some of these questions in front of the entire committee. So with your permission, Mr. Chairman, I'll just proceed through this.
Please do. And just fire away.
I am back on the memorandum from December 25th, where you answered a number of questions. Early periodic screening, diagnostic, and treatment. This appears to be a huge deal, a big package. The package itself, is that optional or is it mandated? Meaning if you take it on, then there are parts of it that are essential and other parts you've added to it. Kind of give us a little bit of a background on the entire program.
Mr. Chairman, Representative Pendergraft, I can answer that pretty succinctly, but we'll defer to Mr. Springer if there's additional questions. This is a Medicaid essentially service EPSDT. That's an overlay on services for children. Essentially, it's a mechanism by which anything that's medically necessary as ordered by a physician, for example, can be covered in the Medicaid program. So it's not really optional to participate in that, but I'll certainly defer to Mr. Springer. We tried to give you a list of optional and mandatory services. We just wanted to caveat that anything with children has an asterisk next to it if EPSDT would authorize its expenditure, if that makes sense. Jesse, anything to add there?
Chairman Bear, Representative Pendergraft, Jesse Springer, State Medicaid Agent. So EPSDT or well child checks is basically anything found during screening of a child or treatment of a child then has to be treated. So it's a mandatory feature of the Medicaid program for children. So, and that's age-based, it's not based on child eligibility. It's actually based on age. And so if we find something that, we find the child has a hearing issue, we may not cover hearing aids. We do, but if we didn't cover them, we would cover them for children to cover that specific hearing issue. So that's why you see a number of services that are optional for adults essentially are mandatory for children. And so we run a different benefit package for children. We actually run an adult benefit plan and children benefit plans for this exact reason. And so those have, in some cases, very different benefits. So for dental, we have a rather robust dental package. For adults, it's very limited. It's to cleaning, extractions, and those sort of things. So that's kind of where this difference comes into play. And that would kind of play out across a large array of benefits where children generally have much more expansive benefits because of EPSDT and honestly other regulations. And adults are generally treated to have much more optional for a state. And if you can choose to offer them for adults or not choose to. And Wyoming has chosen to limit a number of those optional benefits for adults.
Thank you for that. Sometimes you learn things by osmosis, but you never actually heard it said. And so I appreciate the clarity on that. Under case management, you have case management, you have targeted case management, you have primary case management. Could you take a minute and just kind of differentiate, describe, define those parameters?
Mr. Chairman, Representative Pendergraft, again, I'll defer to Jesse for a brief answer. Generally speaking, those follow definitions. For example, targeted case management in our home and community-based waivers for developmentally disabled individuals is different than case management in the state plan, for example. But I'll let Jesse describe a few of those nuances.
Chairman Bear, Representative Pendergraft. So they're really different flavors and different levels of case management. So we have a patient-centered medical home. So we pay $6 a month for that for people that are going to a primary care setting. And that's really covering extended hours, some care coordination, some phone calls. So it's very light, so it's not a heavy, and that can go up to targeted case management where somebody has some level of disability. So they have a mental health issue, they have something else. And so they're getting a dedicated case manager, and those case managers might have a 30-person caseload, and they're actively following those people where a primary care caseload might be 3,000 people. And then you get to the home and community-based services side, those case managers are not managing medical issues, they're managing personal care waiver benefits. They're making sure, do you have someone to care for you? Is there someone to come take you to the events you need to go to? So much more personal life type things. And that's for the comprehensive supports waiver and the community choices waiver. So those are more like home care. Can I stay at home? Can I live a life? But those case managers are generally not managing medical issues. So generally when you see, it frustrated me, like, it's been a long time now, but I was like, why are there so many layers of case management? And generally, we don't have medical case managers and these personal care life case managers that are cross-trained. That is something we do want to look at in the future, that could some of the medical case managers also do some of these life things, so you have one person you're working with, because it does get confusing for some families where they might have 2 or 3 case managers, and if they're involved with DFS, they also have a case manager. So, but generally they're different programs, and the flavor of the case management depends on the type of issue and how severe it is.
Thank you. That is helpful. So we have support waiver, we have comprehensive waiver, and then we have a community choices waiver. How is that not just kind of a catch-all that if you don't qualify for this, or you don't qualify for that, we can surely find a way to squeeze you in here? Is there any fear there? Because I've heard some people express that fear.
Mr. Chairman, Representative Pendergraft, I'll take that one. So your question's well taken. Community choices waiver is certainly not a catch-all waiver for folks who do not qualify for others, like the DD, developmental disability waivers as an example. It is specific to long-term care needs. So for community choices waiver, it is an alternative to essentially nursing home placement. So what it offers is, if you qualify clinically and financially for nursing home placement in Wyoming, and Medicaid would pay for that nursing home placement, the community choices waiver gives you an option to receive that care in your home instead. It's generally lower cost for the state to do that, and generally the preference of our elderly to stay in their homes. So it's very specific eligibility criteria, both on the financial side and on the clinical side. So a nurse has to do essentially a clinical assessment on your activities of daily living to determine if you meet clinical criteria to be served in a nursing home. In conjunction, we would do the financial eligibility criteria to see if you qualify for Medicaid long-term care. If both of those are the case, then you have this option of being served in a nursing home or in this community choices home and community-based waiver.
So, for example, to qualify for the community choices waiver, I might not have to liquidate all my assets quite so quickly. Give me a little bit of respite there. Is that accurate?
Mr. Chairman, there is some accuracy to that. As we've talked about before, Medicaid long-term care eligibility standards are quite strict. So both for nursing home and community choices waiver, those asset thresholds are pretty low, $2,000 plus your income criteria. But there are, certain provisions of that program that, you do not have to, you can have a primary residence, a primary vehicle, et cetera, where that type of spin down wouldn't be as severe as if you're going into a facility.
Thank you. I only have one more.
Sure.
Trying to go quickly. EIEP counts. All 50 states are listed in this chart, and I took Wyoming out of it, and I found that the other states average 5.6% of population served. Wyoming, uniquely, 10.6. Why?
Mr. Chairman, Representative Pendergraft, you just asked a question that's been discussed and debated as long as I've been with the Department of Health. I'll give you my professional opinion on the reasons for our higher than average identification and service rate in this program. Number one, I think you would hear this from our providers and communities too. Wyoming does an excellent job with what's called child find, meaning the screenings and the availability of those screenings for families, parents, et cetera, to get their kid screened for developmental delay or disability. So I think on the positive side of that answer, Wyoming just does a really good job, maybe better than some other states, in screening for that type of eligibility and getting those kids in the door for services. In addition, this is no judgment call one way or the other, but Wyoming is a bit unique in its structure with how we operate EIEP. And just edification of the committee, we're talking about our developmental preschools. That's what EIEP refers to. It's unique in our structure that it's operated out of the Department of Health. Generally across states, and it does vary, most of the time that's operated in state education departments, especially the 3 to 5 year old program. But for a variety of different reasons over the decades, that has lived in the Department of Health. And so I think in other states, you do have different involvement of school districts, for example, that might be the primary providers of these services, where our structure in Wyoming is just a little bit different in that not a whole lot of school districts provide the birth through 5 services that we're talking about here. So that could be an artificial inflation of our percentage there. But your observation is spot on that we are, generally speaking, every year on average higher in our identification rates than other states.
Thank you very much for that. And I just want to take this opportunity one last time, well, maybe not one last time, but one more time, to thank you for your candid answers and for the relationship that we've had. The openness I felt has been very good. Certainly, I feel like I've learned a tremendous amount, but I also realize the more that I learn, how little I know. So thank you for bearing with me.
Mr. Chairman, Representative Pendergraft, story of my last 13 years. The more I look, the less I know sometimes. But I want to thank the committee for your time. Again, apologies if I seemed overexcited about our rural health transformation program, but I do think it's a really unique generational opportunity that we're very excited about getting this operational and standing it up. And we appreciate this committee, the legislature, and your constituents' support going back to September. This was a all hands on deck effort, and the public's participation feedback really did generate our application. And now we can say with some level of certainty the federal government's interest and approval of the ideas that Wyoming submitted. So thank you, Mr. Chairman, and we stand by for any additional questions as you continue your work over the next 2 weeks.
Right. Thank you. Appreciate your being here. Director Richards. Yeah, we're going to take a 5-minute break, but tell us what's up next, please.
Mr. Chairman, I believe the committee was going to make a motion
Okay.
to go into executive session at some point.
All
And you
right.
may also want to advise whether you will be returning from executive session or will be adjourning for the day for those online viewers.
I think we will return to adjourn at the end. So we'll be done as far as public, what they'll be able to view other than our adjourning, and then we'll go on that tour. So 5 minutes. We're on recess. Attorney we got? What- Okay, we need to get into executive session so that we can turn it off. Yeah, if you would, please. As soon as she's got us online. Okay, we're online. I'll entertain a motion.
Mr. Chairman, I'd like to make a motion to go into executive session.
And that executive session is to discuss the possible action by the toward the judiciary in the budget. Okay, do I have a second? Seconded by Representative Harrelson. All those in favor of going into executive session signify by saying aye. All those opposed? Okay, we'll go into executive session. Please secure the video. Somebody be ready to throw a beanbag at anybody that comes in the door. Okay. And we got the